Are you ready to start? Okay. First speaker will be Dr. Ismael Hammam, Senior Consultant, Electrophysiologist, Cardiologist. Welcome, Dr. Ismael. Welcome, please, everybody.
Thank you, Dr. Ibrahim. Thank you, Dr. Mahmoud, for this invitation. Thank you, Novartis, for invitation to talk about Entresto. طبعا our talk title is Improving Heart Failure Patients' Lives and Time to Act Now. We were going to talk the unmet need in heart failure, what we need to do with heart failure patients, and then we need to talk about why heart failure patients cannot wait, and what we need to act immediately with them, and then what is the right agent for all heart failure patients, and why neprilysin inhibition is a must. Again, we'll talk about heart failure. Heart failure, as we know all, is associated with devastating burden on all patients. Globally, estimated number of heart failure, 26 million people. And we know that heart failure is a progressive disease and leading to reduced quality of life, increased hospitalization, and increased mortality. For each patient with new diagnosis of heart failure, it is estimated that one hospitalization per year for any patients with heart failure. And we know that predictors of heart failure hospitalization are comorbidities like atrial fibrillation, obesity, higher hemoglobin A1C, low GFR, and other comorbidities. And not only hospitalization, not only other problems associated with heart failure, also heart failure patients suffer from poor quality of life. Again, prognosis of heart failure remain poor. At 1 year, expected mortality is 20%, and at 5 year, expected mortality can reach up 67%, and this results by Framingham Heart Study and cardiovascular heart study. This is the right time to start patients on Entresto. Heart failure patients cannot wait. Again, with disease progression, patients are at higher risk of hospitalization. With each acute event or with disease progression, quality of life decreases and mortality increases. And with each acute episodes of decompensated heart failure or with each hospitalization of any heart failure patients, there is more myocardial injury and there is more progressive LV dysfunction. Again, initiating Entresto earlier provides superior improvement in left ventricular ejection fraction. When we early start Entresto, we expect better improvement in left ventricular ejection fraction by 7%. According to this PROVE heart failure study, patients who were started on Entresto at the beginning, they have 44%, their ejection fraction increased from 28% to 44%. Other patients who were started on Entresto later on, their ejection fraction increased from 28% to 37%. And we can see the difference between both groups. When we compare patients who were started on Entresto at the beginning or at the onset of heart failure with patients who were started on Entresto after disease progression, we see patients with new onset heart failure who were started on Entresto, they have higher number of left ventricular ejection fraction improvement. Their LV ejection fraction increased by 12.8% in comparison to patients who were started on Entresto during disease progression, and the left ventricular ejection fraction increased by 9.4%. Not only left ventricular ejection fraction improve with Entresto, but we can see that all heart volumes, like left ventricular end diastolic volume, left ventricular end systolic volume, improve with Entresto. Why? Because Entresto, it work on reverse remodeling. It shape the heart, especially in new onset AFib, new onset heart failure. So patients with heart failure, usually their cardiac size and volumes go up and their cardiac output go down. After starting Entresto, reverse remodeling cause decrease in cardiac size and volume and increase in cardiac output. Again, based on the studies in patient in Pioneer heart failure study, patients who were started on Entresto from the beginning, once they have diagnosis of heart failure, they have much better outcome, much better improvement in hospitalization and left ventricular ejection fraction. Pioneer study, they were randomized patients after hospitalization. Once patients hospitalized, and they improved clinically, their blood pressure is okay, they were randomized to receive sacubitril valsartan or receive enalapril, and they were observed for number of 6 to 8 weeks, and then they were compared together, and we can see the outcome improves and both curves separates from the beginning. The group who were assigned to enalapril switched after 8 weeks to Entresto, and we can notice here that the separation of two curves stays the same after switching enalapril to sacubitril valsartan, and this indicates that starting Entresto from the beginning is the gold standard for these patients. Again, heart failure is a progressive disease, and heart failure, stability in heart failure does not mean that patients are not at risk. These data from an old study where they compared patients with class 2 heart failure with a class 3 and class 4, and at that time they noticed that sudden cardiac death occurred at 64% in patients with class 2 heart failure compared to class 3 and class 4. This means that stability of symptoms does not mean lack of risk, and patients have at risk viable vulnerable myocardium, and sudden cardiac death and worsening without worsening of symptoms and without hospitalization is more in this group of patients with stable heart failure patients with class 2 heart failure. And that's why because usually these patients have less symptoms. This group of patients are less likely to receive guidelines directed medical therapy. Again, patients who are assumed to be stable with the class 2 heart failure, they have 20% primary events, 17% died during the trial, and 51% had a cardiovascular death as the first event, and 60% of those cardiovascular deaths were sudden cardiac deaths. Why neprilysin inhibition is a must? Again, with each heart failure patient, we have to target 5 pathways of heart failure modulation. And these pathways work on angiotensin II, norepinephrine, aldosterone, neprilysin, and SGLT. And ARNI, or like sacubitril valsartan or ACE or ARB, work on 2 pathways of these 5 pathways. Again, these 5 pathways should be targeted on every patient with heart failure, regardless of the stage of heart failure. ARNI works on angiotensin II and works on neprilysin. Beta blockers, MRAs, SGL2 inhibitors work on just one pathway of these 5 pathways. ARNI has 2 components, sacubitril and valsartan. And from this diagram, we can notice that valsartan working on angiotensin 1 receptor and sacubitril work on C-type natriuretic peptide and ateronatriuretic peptides, and both of these components work on vasorelaxation, modulation of blood pressure, sympathetic tone, aldosterone level, fibrosis, hypertrophy, and natriuresis and diuresis. Again, Entresto significantly reduced heart failure hospitalization and cardiovascular death across heart failure spectrum. In Paradigm heart failure study, where patients randomized to either Entresto or enalapril, and in the Paragon heart failure study, where patients assigned to Entresto or valsartan, the difference between the 2 studies, in the Paradigm study, they choose patients with left ventricular ejection fraction less or equal 40, and the mean left ventricular ejection fraction was 29%. In patients with Paragon study, they choose patients with ejection fraction more or equal 45%, and they excluded all patients with history of ejection fraction less than 40. And we can see in the Paradigm study, all patients benefit from the Entresto, and all the lines are below the middle line. But in the Paragon study, whenever the ejection fraction goes up beyond 57%, the benefit becomes more or less, and the Entresto becomes equal to valsartan. This is very important. So it's not cardiac remodeling. Cardiac remodeling is a mechanistic explanation for improved patient's outcome. So it increases the left ventricular ejection fraction, it decreases the volume, both in diastolic and in systolic volume, and it decreases the filling pressures. And all of these parameters are the mechanism how ejection fraction improve or how outcome improve in these patients. Again, Entresto affect also secondary functional mitral regurg according to these studies. In the Paradigm heart failure trial, cardiovascular causes accounts for 81% of all death. And Entresto significantly reduced the number of sudden cardiac death compared with enalapril by 20%, and we can see the both curves separates from the beginning. Again, Entresto reduces the risk of serious adverse renal outcomes and slows the decline of GFR irrespective of baseline renal function. When we combine both groups, the Paragon heart failure patients group and the Paradigm heart failure group, we can see the effect of sacubitril valsartan compared to valsartan or enalapril on kidney function.
1
Again,
minute.
these are
1 minute, please, Dr. Ismail. 1 minute only.
1 minute. Okay, I will go quickly.
Thank you.
So I will skip this and I will skip this. Again, guidelines position Entresto as a preferred first-line treatment across heart failure spectrum over AC inhibitor and ARBs. ARNI should be initiated from the beginning, and all patients with New York Heart Association 2 to 3, and they should use ARNI to reduce morbidity and mortality, and this is a class 1A indication. Not only improving outcome, but ARNI has a very good high value. This is the first time to compare all groups of heart failure medications in regards of economic or cost. ARNI has a high value because it prevents hospitalization, it improves outcome, so it improves, economic value for compared to other medications. I will go quickly. So Entresto significantly reduced death from cardiovascular causes or first hospitalization for heart failure and improve quality of life. This is the message. Titration, we need to up titrate and achieve the target dose of Entresto, since in the paradigm study 67% of patients remained at a target dose of 200 milligrams twice a day. Patients who achieved and maintained the target dose of 200 milligrams were more protected and had lower cardiovascular event. To conclude, time is muscle. This is very important. This is the message of my talk today. We need to start Entresto as soon as possible. And if we delay starting Entresto as we shown in this lecture, effect or cardiac outcome will be less desirable than when we start it as soon as possible. Thank you.
Thank you, Dr. Ismail. We will move to our next speaker, Dr. Mohamed Jabari. Questions will be at the end.
Assalamu alaikum.
Dr. Mohamed Jabari is a senior interventional cardiologist. Please, Dr. Mohamed.
شكرا دكتور إبراهيم. اوكي. محمود طلب مني 15 دقيقة، المفروض يعني أكثر من هيك، بس أنا I will try to be in a hurry. Okay. Yes, okay. I will begin immediately. Cardiovascular disease are the leading cause of death worldwide. We have almost 17.8 million people died from cardiovascular disease. If you see down that 8.9 million deaths is due to ischemic heart disease, whether it's male 55% and female it's 45%. And also we have 2.9 million deaths due to ischemic stroke. And also there is 3.3 million deaths due to hemorrhagic and other strokes. So overall we have 85% of all cardiovascular deaths are due to heart attack and strokes. So early intervention is very important to reduce the cardiovascular deaths. If we see here, we have many risk factors such as hypertension, hypercholesteremia, diabetes, smoking, etc. These risk factors will lead to increase the cardiovascular death. So if I intervene immediately and early, as I give my patients such as statins and antihypertensive medications, and this will lead to decrease the rate and to decrease the heart attack for these patients. So early intervention is very important for these patients. Reducing the risk for cardiovascular disease, we should go for and focusing more important about lifestyle modification. Our patients should stop smoking, reduce the salt and fat diet, eat more fruits and vegetables, and do exercise, and avoid the harmful use of alcohol. What about the medication to reduce the risk of cardiovascular death? We need a proper controlling of blood pressure, proper controlling of diabetes, stop smoking, and good management. I will focus in this lecture about the cholesterol. Worldwide, there is a global increasing in the total cholesterol level. We have almost 39% of all world adult population, as seen in this slide, increasing the cholesterol level. What affects our cholesterol? Number one, diet and exercise. Number two, regarding the age and gender, and also hereditary is one of the important causes for our high cholesterol. Being overweight can increase the LDL cholesterol. Saturated fat, trans fat, and cholesterol in our food will increase cholesterol level. So regular exercise can lowering our LDL cholesterol and raise our HDL cholesterol. What about the age and gender? Cholesterol level increasing with age, as many diseases, as hypertension, as atrial fibrillation. What about the hereditary? It's very important to know gene partly determine how much cholesterol the body makes, and the high blood cholesterol can run in families. So, management for cholesterol to reduce cardiovascular disease. This is very important slide. Show that the high cholesterol level will increase the risk of coronary heart disease and the stroke. So, what about the statin in these patients? Statin are the most potent drug available to reduce the LDL cholesterol. We should lower the blood cholesterol by 20 to 60%. Recommendation by multiple international guidelines as show that this is a first line treatment reducing the LDL cholesterol. Before prescribing a statin, a doctor should consider cholesterol level, the degree of the cardiovascular risk. Atorvastatin has been shown to reduce the cardiovascular in clinical trials, as will shown here, that statin therapy is effective in reducing cardiovascular death. Statin therapy reduced the risk of the stroke by almost 30%, reduced the risk of the coronary heart disease and death by almost 36%, and here in the combined risk of the heart attack, revascularization, and stroke mortality, it will be reduced by 50%. And here in all the guidelines, the American and European show that statin recommendation as the first line treatment of our high cholesterol across the range of the patient types, whether the patient is at risk of cardiovascular disease or the patient is diabetic. This is very important slide. European guidelines, 2019 guidelines, how to treat and what is the goal. The treatment goal for the LDL cholesterol level as shown here, that very important here. Okay, this one, when we started to treat our patient, we should indicate the drug therapy, definite treatment, and the treatment goal for the patient. We should give him high potent statin at the highest recommendation and tolerate the dose to reach the goal. If the LDL goal is okay here, so we will follow him annually. If not, what should we do? We add ezetimibe for this patient if we are not reaching the LDL goal. And if after adding LDL with a statin and the patient is going okay and we're reaching the goal, and we will know now what's the goal for that, we will follow him up annually and more frequent if indicated. But if not, we will consider nowadays add a PCSK9 inhibitors. Considering adding this medication is very important after failure of the statin and ezetimibe therapy. Here is very important slide, show that the goal, they classified that we have a very high risk patients, and moderate and low. If we have a very high risk patient, the goal of the LDL should be below 55. And if we have a high risk patient, the goal, it should be below 70. And if we have moderate, it's almost 100 and below. So we will focus more important about very high patient. Who's very high patients and the high patient? The very high patients whom that go with the scoring more than 10%, and we have an family history and atherosclerosis diseases and major risk factors and severe chronic kidney disease, diabetes, and target organ damage more than 3 measures. This is a very high risk patients. We should reach to LDL below 55. What about the high risk patients? The high risk patients whom scoring between more than 5 and less than 10% and markedly elevated single risk in a particular LDL above 109 and the family history without other major risk disease or a moderate chronic kidney disease or diabetic without target organ damage. Should we, these patients with the high risk, should we reach the target of the LDL below 70%? What about the guidelines? The guidelines, European guidelines recommendation for these patients with acute coronary syndrome. Number 1, in all patients with acute coronary syndrome without any contraindication or a definite history of intolerance, it's recommended that high dose statin therapy is initiated, continue as early as possible regardless of the initial LDL cholesterol. This is a class 1 indication. Lipid levels should be re-evaluated after 4 to 6 weeks after acute coronary syndrome to determine whether a reduction it's more than 50% from the baseline and the goal level less than 55 milligram per deciliter have been achieved. This is a class 2A. If the LDL cholesterol goal is not achieved after 4 to 6 weeks with the maximum tolerated statin combination with ezetimibe, this is class 1. And if after 4 to 6 weeks also after combination and we are not reaching the goal, we should add a PCSK9 inhibitor. It's class 1 indication. Regarding during a very high risk patient with PCI, the guidelines said that routine pre-treatment or loading with a high dose statin may be considered in a patient undergoing PCI for an acute coronary syndrome or elective PCI. This is class 2A. What about the ischemic stroke? The guidelines said that patient with history of ischemic stroke or TIA at a very high risk, particularly they have a recurrent ischemic stroke, so it's recommended to receive intense LDL, and this is also class 1. What about the patients with a chronic kidney disease, moderate to severe chronic kidney disease? It's recommended that patient with a stage 3 to 5 chronic kidney disease are considered to be at high or very high risk. It's class 1 indication. The use of a statin or a combination with ezetimibe combination is recommended in a patient with non-dialyzable dependent stage 3 to 5. What about the peripheral, including carotid and peripheral artery disease? In a patient with peripheral, we should give him statins plus ezetimibe or a combination with PCSK9 inhibition if needed, and it's recommended to reduce the risk. It's class 1. So, if you see here in the SPARK regarding the total vascular problem, that atorvastatin 80 may reduce almost over 6 years 20 vascular events in a 100 participant patients were avoided from the total vascular and cerebral and coronary vascular problems. And also in the TNT showed that atorvastatin reduced the risk of a cardiovascular by 22% in a patient with stable coronary heart disease in comparison with 10 milligram. What about the PROVE-IT? Show that atorvastatin reduced the risk of death and major cardiovascular by 16% comparing pravastatin 40. So how should I monitor our patient? How often should lipid be tested? First, before treatment, I should do almost 2 tests with an interval between 1 to 12 weeks. 2 tests to make sure that they have a problem in his lipids. After that, I will adjust between 4 to 8 weeks to reach the goal in 1 year. This is very important. What about the adverse effect of statin? All of us know that we have a little bit of muscle problem, liver, and new onset diabetes. What about the muscle? The myopathy. Most clinical adverse effect interact with concomitant drugs should be considered. Rhabdomyolysis in 1 to 3 cases per 100,000 patients per year, they will have elevated CK more than 10 the upper normal. What about the liver? No indication that statin may cause any worsening in the liver disease. And the new onset of diabetes, if there is a development of a new onset, is 1 case in a 255 patient over 4 years, that the elevations of hemoglobin A1C minor and not clinically relevant. Here is the safety between the 2 doses of atorvastatin 10 milligram and 80 versus the placebo, that we show that there is no significant between 10 and 80 regarding the withdrawal linked to adverse effect, the serious treatment with non-fatal adverse effect, myalgia, persistent elevation of liver function, and the CK and rhabdomyolysis also. This is very important to be known that the established renal and the atorvastatin are shown in the Planet 1 and Planet 2. Planet 1 and Planet 2 studies showed that these are patients with the CKD patient with type 1 or type 2 diabetes in the Planet 1, and the Planet 2, this is a CKD without diabetes. There are mostly male or female above 18. They have moderate proteinuria. They have fasting LDL more than 90, and they are both on ACE inhibitors or ARBs more than 3 months. This study what showed? In the secondary endpoint, as we see, if we are focusing on the GFR, that unlike rosuvastatin, atorvastatin show no significant in the green. If you see in the blue one, no significant changes in the eGFR. And also here, again, diabetic patient with high cholesterol, they have moderate proteinuria. Changing in the GFR, there is no change in atorvastatin 80 in comparison to rosuvastatin 40 and rosuvastatin 10. The change in the urine protein creatinine ratio from the baseline after 52 weeks decreased in the arm of atorvastatin by 12%, whereas in the rosuvastatin less than 5 in the 40 milligram dose and less than 5 in the 10 milligram dose. On the other hand, there is adverse effect where the highest rosuvastatin 40, that they show that there is acute renal failure occurred in a patient and serum creatinine doubling in almost 6 patients. So among patients, diabetic or not diabetic, with moderate proteinuria, atorvastatin appeared to be superior than in preventing the renal damage.
Please, Dr. Mohammed, please conclude.
This is the last slide. This is important slide. Show that how should I treat statins in comparison if my patient have a CKD patient stage 1, 2, or stage 3, or stage 5. If you see here, atorvastatin in doses 10 to 8 milligram in stage 1 or 2, no dose adjustment, stage 3, no dose adjustment, and in stage 4 or 5, no dose. In comparison to rosuvastatin, it's 5 to 40 milligram in stage 1 or 2, it's 5 to 20 in stage 3, and in stage 4 to 5, it's almost 5 to 10. And thank you for listening. Always remember, Jerusalem is the capital of Palestine.
Thank you, Dr. Muhammad. Let's move to the next speaker, Doctor. Maybe you want to tell us who's the next speaker.
Thank you very much, Dr. Mustafa, Dr. Ibrahim. I asked Dr. Mahmoud why you put the distinguished sessions in the end. He said that to keep all the attendings, and we have a distinguished speakers from the Jordan, Dr. Ismail, and Dr. Mohamed Jabari, and Dr. Islam Abu Seedo. He is a consultant, interventional cardiologist. He will talk about role of Ticagrelo in acute coronary syndrome. He's working in Al Arabic Cardiac Center. The floor for you, Dr. Islam.
Thanks, Mr. Chairman, for this invitation. Thanks for organizing committee. So today I will tackle acute coronary syndrome, redefining the standard of care with the role of Ticagrelo in particular. So as you know, acute coronary syndrome has a major burden in mortality and morbidity. Post-myocardial infarction patients, unfortunately, they are at high risk of further ischemic events. Unfortunately, about 1 in 5 patients suffers another MI, cardiovascular death or stroke within the first year from having an acute coronary syndrome. Those patients with a history of ischemic events, unfortunately, have a continuous and a linear risk of major adverse cardiovascular events for more than 3 years after a heart attack. This comes from the REACH registry, tackling almost 21,000 patients with ischemic events at the baseline, and you can appreciate how it is having significant mortality, morbidity down the road after 3 years. From this, another cohort, which is the preclude myocardial infarction, those patients post myocardial infarction, unfortunately, at a significant high risk of further ischemic events, and they require appropriate cardiovascular event. And the risk of recurrent myocardial infarction, unfortunately, was twice as high in the non-culprit lesion over the culprit lesion. So this is unexpected, to be honest with you, but from this registry, we appreciate that these vulnerable plaques actually, they form the major role of having another event down the road. Now, as you know, those with non-ST elevation myocardial infarctions, they form almost 2/3 of the patients coming with acute coronary syndrome. They still remain at high and persistent risk of cardiovascular event post-discharge from the hospital. So 2-year rate of myocardial infarction, stroke, all-cause mortality in non-ST or ST patient above age of 65 from this actually US action registry showed that while both non-ST and ST elevation myocardial infarction patients are at high risk of recurrent cardiovascular events, non-ST elevation is really associated with almost a significant greater number risk compared to those patients coming with ST elevation myocardial infarction. Now, antiplatelet medication timeline, this is the evolution. We learned long ago from the ISIS trial the major role of aspirin, and subsequently we learned that we have a lot of those antiplatelets that play a major role in those patients coming with acute coronary syndrome. With the fund of these trials from the CAPRI, CURE, COMET trial, CLARITY, Triton, TIMI 39, and finally from other major trial, the Plato trial, this history actually of dual antiplatelet therapy actually changed the whole sequelae of acute coronary syndrome management. Now talking about clopidogrel with the variability from 300 dose to 600 dose, now we learned that the 600 actually did way better regarding platelet inhibition, how it worked faster and how it inhibits more platelet in comparison to the loading of 300. And the pioneer, Dr. Salim Youssef, who actually was the pioneer investigator in this particular aspect. Now, US FDA has updated actually clopidogrel prescription information and recently removed the reduction of cardiovascular death from non-ST elevation myocardial infarction indication of clopidogrel. So in September 2016, US FDA has updated clopidogrel prescription information and removed the reduction of cardiovascular death from non-ST indication of clopidogrel. But the indication of ST is now specific actually to medically managed patients only. And as you know, that ticagrelor is the only P2Y12 inhibitor with a direct action. So it's not a pro-drug and does not require metabolism to become therapeutically active compared with the comparator clopidogrel. It has two paths. It works in a dual mechanism of action. The first one inhibits P2Y12 receptor with a significant effect on the platelets. And the other path is the inhibition of ENT1 transporter with a lot of effective points with a cardioprotection, modulation of inflammation, and unfortunately, it's on the expense of shortness of breath and dyspnea. Now, as you know, ticagrelor, adenosine-mediated effect, this is the evidence and potential clinical relevance. So several studies consistently showed that ticagrelor inhibits the cellular uptake of adenosine, and this is where we find additive actually value of ticagrelor on the expense of worsening shortness of breath. In this cohort, the onset and offset trial, where they randomized 123 patients with stable coronary artery disease taking aspirin, and the other arms involving ticagrelor and clopidogrel, and they follow these patients. What we learned from the onset and offset trial that ticagrelor 90 milligrams provided actually faster and greater inhibition of platelet aggregation compared to clopidogrel. And this is the unique thing about and comparison between those actually antiplatelets available in the market with, as you see here, comparing clopidogrel and prasugrel, where they are pro-drugs and belongs to thienopyridine group. Ticagrelor actually works directly and reversibly interacts in P2Y12 ADP receptor and actually is an active without metabolism, so they are not a pro-drug. and the mean time of elimination is pretty much 7 hours. This is just to look at the characteristic of the other P2Y12 inhibitors, the clopidogrel and the prasugrel. This is just to show you what is the minimal discontinuation and reimplantation time frames of DAPT for patients undergoing elective surgery. And actually, we face this in practice or in daily practice. So for the prasugrel, you have to stop the medicine for 7 days before having elective surgery. And for the clopidogrel, you need to discontinue the medicine for 5 days. And the case for the ticagrelor is only 3 days, where you have to stop the medicine before elective surgery. So how this molecule actually conveyed to the guidelines. So this is the most recent guidelines for recommendation of antithrombotic treatment in MI undergoing PCI. So in STEMI patient with a class 1A indication, a potent P2Y12 inhibitor, ticagrelor or prasugrel, or clopidogrel, if these are not available or are contraindicated, is recommended before PCI and maintained over 12 months unless there are contraindications regarding bleeding. So a P2Y12 inhibitor is recommended in addition to aspirin, maintained over 12 months for those patients with non-ST elevation myocardial infarction unless contraindication or excess risk of bleeding. Ticagrelor, irrespective of the preceding P2Y12 inhibitor, which is extremely important, gaining class 1B recommendation. For prasugrel and P2Y12 inhibitor, it should be a naive patient in order to start it, who proceed to PCI, and clopidogrel only when prasugrel or ticagrelor are not available or contraindication. So these actually are the most recent updated guidelines regarding antithrombotic patient post-MI in patient undergoing PCI. In 2021 European Society Guidelines on Cardiovascular Disease Prevention and Clinical Practice, so they concluded that there are conflicting data as to whether prasugrel is preferable over ticagrelor. There are a lot of debate about this issue, but this is an updated statement coming from the European Society of Cardiology debating whether prasugrel or ticagrelor are better. And regarding the comparative efficacy and safety of oral P2Y12 inhibitor in acute coronary syndrome, a significant actually mortality reduction was really observed with ticagrelor only. And you know, as per the guideline, they come actually from a significant randomized controlled trial. So this is the trial that changed actually the guidelines, the Plato trial. And I'm quite sure that you know, and you heard about a lot of, I have to skip the demographics and the design of the trial. This is just to show you that ticagrelor 90 milligram actually reduces relative risk early and occurs over 12 months versus clopidogrel with a 16% relative risk reduction, having a primary efficacy endpoints of reduction of the cardiovascular death, myocardial infarction, or strokes over 12 months. Same thing happened regarding cardiovascular death in particular. So if we dissect the outcomes, we're gonna get a 21% relative risk reduction of cardiovascular death over 12 months. And ticagrelor apparently reduces myocardial infarction events significantly within 12 months with a 16% relative reduction compared to the older generation, the clopidogrel. In non-ST elevation MI, ticagrelor showed a consistent reduction in recurrent cardiovascular events over clopidogrel with a 17% relative risk reduction in MACE patient with ST compared to clopidogrel. And of course, the most important is what about stent thrombosis? So ticagrelor actually reduces the stent thrombosis by 33% compared to the standard of care at that point, which was the clopidogrel plus aspirin. And that was not on the expense of bleeding. So safety profile of this molecule was greater, to be honest. It has demonstrated no increase in overall major bleeding or fatal bleeding over clopidogrel. Now, tackling the point of shortness of breath and dyspnea, apparently from the Plato trial, we learned that the incidence of dyspnea was significant compared to the clopidogrel, and patient who discontinued the treatment secondary to shortness of breath was significant compared to clopidogrel. But I have to clarify that ticagrelor was associated with mostly mild to moderate intensity and did not actually reduce the efficacy. And the most events, which were 87% that reported, was a single episode occurring only early after starting the treatment. And there was no reported serious adverse except in 0.7% of the patients, compared to 0.4% for those who got clopidogrel. So there was no indication of any adverse effect on pulmonary function, and in 2.2% of the patient, investigators considered dyspnea actually causally related to treatment with ticagrelor. So in order to solve this issue in patients with new onset dyspnea, the history and physical examination apparently is the mainstay of diagnostic evaluation. Always assess the cause of the shortness of breath that your patient coming with acute coronary syndrome have. Sorry. Okay. So always assess the cause of shortness of breath. Remember that shortness of breath is a common actually in ticagrelor arm more than those who got clopidogrel. But usually acute coronary syndrome patients actually reported shortness of breath who have a high risk profile, and they should be managed with the most effective treatment, keeping in mind that you have to balance risk and benefit ratio when you are dealing with this situation. So in conclusion of the Plato trial, ticagrelor compared to clopidogrel in patients with ACS, it reduces significant death, vascular events, myocardial infarction, and strokes. A beneficial effect of ticagrelor was achieved significant increase in the, without a significant increase in the rate of major bleeding. So I have only 1 minute. So ticagrelor was effective and safe in a broad spectrum of acute coronary syndrome patient, in particular elderly patient, diabetic, and it was actually analyzed well from the Plato trial on CKD patients. So across the board, the range of acute coronary syndrome, you have a molecule that is very safe, regardless of the weight of the patient, regardless of the age of the patient, regardless of the comorbidities, and was not on the expense of the bleeding. So the starting point, remember that this molecule is wonderful for those patients, and we have proved it actually in ST elevation and non-ST elevation patient. Last thing that I like to share with you is the de-escalation. Remember, sometimes we have to de-escalate our treatment based on the side effect of the patient. We learned from the SCOPE trial that switching from prasugrel or ticagrelor to clopidogrel in early phases of acute coronary syndrome was associated with adverse clinical event at short-term follow-up. And from other cohorts, we learned that de-escalation might be safe, but it is associated with high risk of ischemic event as compared to ticagrelor. So de-escalation unfortunately might increase platelet reactivity. With that, I conclude. Thanks for your attention.
Thank you very much, Dr. Islam, for this nice presentation. And I will ask the speakers to come to the floor for the discussion. First from the chairmen, if they have some question for the chairman, Dr. Ibrahim, Dr. Mustafa, Dr. Karim.
Yes.
Will ask
I have a question for Dr. Ismail, please. If we have any new data about the mechanism of action for the Entresto, you can tell us.
What is the question? Sorry.
The question is if there is any new data for the mechanism of action for the Entresto.
No, mechanism of action is known for Entresto, and as I mentioned in one of my slides, there is two components of Entresto action. It affects angiotensin receptors This is number one, and number two, it inhibits neprilysin. And both of these two actions act on heart remodeling and what I mentioned as modulation of blood pressure, vasorelaxation, affecting natriuretic peptide, diuresis, all of these known components.
Thank you.
Dr. Islam, according to Plateau, they had to discontinue Brilinta in 0.9% of cases where people had dyspnea, while dyspnea is common. From our experience, maybe more than 20%. How do you explain this? They had to discontinue Brilinta only in 0.9% of cases. Did they leave their patients suffering of dyspnea?
This is a nice question. Dr. Mustafa is asking about the rate of discontinuation of Ticagrelo. In the Plato trial, they reported actually almost 17% reported cases of shortness of breath. So, but the discontinuation rate was less. So this can be justified easily because they actually, this is what we have to do, is first of all, not to give this patient to an advanced COPD or asthmatic patient. This is actually should be given. So it's not recommended to start it with advanced COPD or asthmatic patients in particular, this population in particular. Now, for the other sequelae, you know that most of the patients actually, they have a mild to moderate shortness of breath. So you can reassure your patient. We've been facing this and we noticed that in the practice in US when we used to give adenosine actually for those patients who have a stress test. So immediately they start to have a shortness of breath. Once you give them some caffeine, actually, you negate this result. Actually, you get those patients count and no more shortness of breath. So if you reassure your patient that this is very transient, if you give him something actually to negate the side effects of the other pathway, which is, I just mentioned, the adenosine pathway, I guess this is what happened in the trial, in the Plato trial. So they reassured the patient, they gave some caffeine, and it was mild to moderate cases that reported that did not discontinue the medicine. But those who discontinued the medicine, I agree with you, they were reported as 0.9 from the Plato trial, but they did not reach a significant, actually, they have a significant p-value compared to those patients who got clopidogrel, but I mean, you can reinforce the importance of this medicine.
Dr. Ismail, you mentioned a very nice phrase about the reshaping use of Entresto in heart failure and reshaping of the heart failure. So the end result is reshaping or remodeling, reverse remodeling. From the physiological point of view, most of the drugs that act on heart failure or the prognostic agent, they act on the mechanism of according to the Frankenstein law and length tension relationship. So what we meant by reshaping is that the reversing of the bridge and actin and myosin bridge to put the heart work in a very reliable and physiological length tension relationship. This is the main mechanism and the end result of using of neprilysin inhibitor and AC inhibitor. So the word reshaping and reverse remodeling is very nice to describe the effect of the neprilysin inhibitor in heart failure.
Okay, Dr. Ayman.
Dr. Ismail, just a comment.
Okay.
In a clinical practice, we may face patients with a grade 3 or grade 4 heart failure, and they are hypotensive. Which one of the 4 drugs we sacrifice for the sake of hypertension?
Yes, I agree. This is the main issue with Entresto. But if in one slide we mentioned that 76% of patients who were enrolled on the Paradigm study, they reached the maximal dose of Entresto 200 BID. and this is our target. The problem sometimes with hypotension, I think recent data, talk about starting the 4 pillars together at the same time for heart failure patients, and clinically sometimes this is not relevant. I think we can adjust case by case. So you have to study the patient and see how things are going on with him. So you can, if he's hypotension, you can start with 1 pillar instead of another, and then adding other pillars, and then you can up titrate doses. But for Entresto, as I mentioned, it is very, very, very beneficial to start it as soon as possible, as I showed in the Pioneer study when they switched enalapril after 8 weeks to Entresto, the benefit was less than starting Entresto from the beginning. So sometimes I start with 25 milligrams once a day, and then I go up with the dose. I think personally, Entresto for new patients with heart failure, beta blocker of course is number 1, then Entresto is number 2. Then we can add other medications.
Thank you.
Well, we unfortunately we have short time because of the prayer time after 10 minutes. So we will take 4 questions. First, Dr. Ayman, then Dr. Abdullah, then here 2 questions. Okay? Thank you very much. Okay, 3 questions here. Okay.
I have a question and a comment. Practicing in the United States for almost 30 years, I almost never seen shortness of breath with Ticagrelo. But practicing for a year in Jordan, almost everybody gets short of breath. I think there might be some racial differences that the older studies did not include, or because everybody in Jordan smokes. My comment, Dr. Hammam, I think I wouldn't take my patients of any of the 4 medications. I will try to reduce the dose of each one rather than take one completely out. And of course, we start with the diuretics because each of these medications has its own beneficial effect. My question to Dr. Islam is, what's your take on Ticagrelo 60 milligram after the year? The risk never goes out after the year, but we don't have it here in Jordan. But what's your take? Thank you.
Well, that's a great question answered I think in the Pegasus trial. So actually they gave the 60 milligram twice a day following the first year of acute coronary syndrome, and apparently it demonstrated actually a nice reduction in events down the road. But I don't know actually, the guidelines, they de-escalated from class 1 indication to class 2B indication that may be considered after the first year. So probably that was because of the problem of bleeding. That was in the expense of bleeding ratio. But so the guidelines, they actually implement this in particular after the Pegasus trial. So they mention it clearly that it may be beneficial for our patient after the first year of acute coronary syndrome. And the reason why they escalated to 2B class, I think it was because of bleeding compared to aspirin alone.
Yes, Dr. Abdullah, please.
In the same context, adding for patients with chronic AF who present with acute coronary syndrome, adding Brilinta to prior NOAC is risky. So can you elaborate on this and how you manage these kinds of patients?
So Dr. Abdullah is asking a great question for those patients actually who have atrial fibrillation with acute coronary syndrome. So apparently the data supporting clopidogrel over other antiplatelets for the sake of bleeding risk. So what do we do? Actually for acute coronary syndrome is we start with a triple therapy for a 1 month aspirin, clopidogrel and full anticoagulation. And after the first month, then we skip aspirin and we continue with clopidogrel plus oral anticoagulant. And even in the chronic situation, actually for those who had a chronic coronary syndrome with a new onset of atrial fibrillation, you even can skip the aspirin after the first week even. You can skip it and you continue with clopidogrel plus actually full anticoagulation. and they address even those patients who are at high risk, patients who are at high risk of bleeding. Now you lower your target for those patients at high risk of bleeding. So if you're giving warfarin, the target is not 2 to 3 actually, the target is 2 to 2.5 INR for those at high risk of bleeding. And actually you are allowed to reduce the dose of full DOACs. Whether you're giving rivaroxaban, you can de-escalate it from 20 to 15, and you can downgrade your target with apixaban to 2.5 by 2 for only high-risk patients of bleeding if you have to give antiplatelet for those patients.
Yes, please. Yeah.
When to stop antiplatelet in a case of elective surgery, but you hadn't told us in a case of emergency surgery when to stop this drug, especially clopidogrel.
Okay, let me be frank from cohorts and from a simple experience in our practice. For those emergent cases, there should be no delay for taking those patients to open heart surgery. I have a patient who was loaded with 600 clopidogrel and taken the same day to OR because of emergency open heart surgery for this patient. He had a triple bypass or quadruple bypass, and the bleeding was almost very minimal. And I had another case scenario that was done last week with a patient who was loaded with Ticagrelo in the emergency department. Afternoon, he was taken to OR because of left main disease, heavily calcified, 80-year-old. He did not bleed apparently. So let me be frank, if we need to take our patient emergently, there is nothing to bind us from taking them to
just one point.
Open heart.
It is said that for clopidogrel it should not be stopped in less than 24 hours.
Should not be stopped?
In less than 24 hours in a case of emergency surgery.
You're talking about antiplatelet?
Yeah, this is established. Because it has longer time of action other than other prosagrel and Brilinta. But for Brilinta, it should not be stopped in a case of emergency surgery in less than 24 hours.
Okay, please, we have only 3 minutes.
Discuss
please.
It. All right, thank you, sir.
I'm not going to ask him questions. I want to be at some points.
صوتك محمد صوتك.
I'm going to add some points which is very practical. For the Entresto, recently there is FDA extension to use Entresto in patients with preserved LV function, not necessarily with bad LV or low LV. So heart failure with the preserved LV function, Entresto significantly decrease the MACE and mortality. Secondly, as we know, the statins make a revolution in the cardiovascular protection, but we concern almost always about the diabetes. I have one study showed that 9% of patients receiving rosuvastatin developing diabetes. So there is a new statin which is not very available in all countries, which is pitavastatin. Pitavastatin significantly improved the hemoglobin A1C incomparable to the other statin, which is considered to be potent statin with no risk of diabetes in the future. Thirdly, I want to add very practical point regarding dual antiplatelet in acute coronary syndrome and chronic coronary syndrome. Acute coronary syndrome, we are talking about STEMI, Tica or plus, or prasugrel, it's more superior than clopidogrel with the class 2A indication instead of clopidogrel. In case of non-STEMI case, the prasugrel is more superior than the Tica, according if you are follow the ISAR-REACT trial. ISAR-REACT trial showed that the prasugrel significantly decreased the MACE incomparable to the Brilinta because significant improvement in the endothelial function. In case of chronic coronary syndrome, clopidogrel is a reasonable first option in all cases, with exception recently, Tica or Brilinta might be useful as a comparable result to the clopidogrel. Finally, in case of when you're going to implant a cover stent, prasugrel is the first choice and comparable to others because prasugrel do not have resistant and comparable to the Tica or clopidogrel. Thank you very much.
You're welcome. Okay, last question, please.
It's not a question, it's comment about the using of the prasugrel or Ticagrelo in the chronic coronary syndrome. till now it is not recommended in the chronic coronary syndrome, in both of them, even the medical treatment or PCI. You mentioned that it may be used in this table, which is chronic coronary syndrome.
Yes.
The second comment about the duration of the antiplatelet, not duration, all of the cases for the 12 months, but maybe according to the bleeding risk and the thrombotic risk, maybe to one month, 3 months, 6 months, according to these, or more than one year, according to the both of risk, bleeding risk and the thrombotic risk.
Thank you for the comment. I think it is time for prayer time, Dr. Mahmoud. Dr. Mahmoud, I think it is time for prayer time, right? Yes, where they will pray here. Yeah, and then we move to the lunch.
نعم. صلاة الآن يا جماعة.